So good evening everyone, this is Dr. Vineet Sehgal and welcome to our session today, that is the rapid revision session on the lens and cataract. So hope you would enjoy the session. This session would be based upon that similar pattern which I have taken the sessions in this month of June. We would be having a lot of MCQs, and after the MCQ I would be just giving you 10 to 15 seconds to answer, and then we would discuss the relevant questions. Okay, so before I start, this is the compulsory voice and the video check. Am I audible to all of you? Give me a thumbs up. Till then, let me set up my top box. Okay, so fair enough. Let's start our session today, that is on the lens and cataract questions in the rapid revision series. Give me a thumbs up. Okay, so before I start the session, I would be just telling you that there is a limited time offer where you can basically go for a 3-year subscription at just 58,500. If you want to go for a 2-year subscription of the iconic subscription, you can get it at only 49,500. If you want a 1.5-year subscription, you can get it at 45,000. And if you want a 1-year subscription, you can get it at a price of 40,500. So you are getting a lot of discounts on the Unacademy iconic subscription for the NEET PG preparation. Okay, chalo, let's start our session. Today our session would be on the lens and cataract. So my first question is on the lens is derived from which of the following? Your options are surface endoderm, neural ectoderm, surface ectoderm, neural crest cell. Try to answer. So very good, Laj. The answer here is surface ectoderm. The lens is derived from surface ectoderm. Now one similar question is that we have two muscles on the iris. This is also a commonly asked question. Sphincter pupillae and dilator pupillae. Can you tell me which embryological layer they are derived from? So my question is sphincter pupillae and dilator pupillae, they are derived from which of the following layers? The options remains the same. So then the answer becomes neural ectoderm. Okay, so they are not, though they are the muscles, they would not be derived from the mesoderm, they would be derived from the neural ectoderm. An important point to remember. Okay, chalo, let's move to our next question. Next question is, which of the following is the protein responsible for maintaining the transparency of the lens? So we have the water soluble and the water insoluble proteins. So my question is, which of the following is the protein responsible for maintaining the transparency of the lens? Am I audible? So the answer here is aquaporins. Okay, so we have the MIP26 protein, which are also called aquaporins. Now they are responsible for maintaining the transparency of the cell. Now another question they can ask sometime is that which is the most common protein that is seen in a crystalline lens? So if they ask most common protein that is seen in the crystalline lens, then your answer becomes gamma crystalline. Sorry, then it becomes beta crystallines. We have 3 types of crystallines: alpha crystalline, beta crystalline and the gamma crystalline. They are the water soluble type of proteins, and the most common of them is the beta crystallines. Okay, chalo, let's move to our next question. Next question is, iris shadow is a sign of which of the following? Your options are mature cataract, hypermature cataract, immature cataract. So very good. The answer here is immature cataract. Now what is happening as a iris shadow? When the light rays basically travel and they hit an object, they can basically present a shadow at a surface. Okay. So what is the most important thing whenever the shadow is Lakshmi, is there any issues with the connection? Am I audible, everyone? Okay. So what is happening is whenever the light is basically called hitting a surface, okay, then it can basically present a shadow. The two most important things which are important for the shadow is that you should be having a opaque surface, okay, and there should be a distance between the opaque surface and the object. Okay, that is very necessary for the shadow being formed. Okay, so let's say this is the iris and this is your nucleus. Let's say the patient is having a immature nuclear cataract. Okay, so what would happen is that in this case the shadow of the iris would form over the nuclear opacity. Okay, so that's why iris shadow is formed in a immature cataract. Now what is happening in a mature cataract or a hyper mature cataract? I would just show you by the help of a diagram. Let's say this is the iris, and we have a mature cataract. So in the mature cataract there is no space between the iris and the lens. Okay, so there is no intervening space. Because there is no intervening space, so there is no shadow that can be formed. So in a mature and hyper mature cataract you cannot have a shadow. The same thing is in the glaucoma, because what is happening is because there is no opacity, the lens is clear, so you are not having a surface at which the shadow can be formed. Okay, so the answer here is D, that is immature cataract. Do you all get my point, Lakshmi, Shirosi, Raj? Okay, chalo. Let's move to the next question, that is upon the ectopia lentis, okay, which is called a subluxation of the lens. Now our options here are congenital ectopia lentis. You have to talk about the direction of the ectopia lentis. Superotemporal, Weil-Marchesani syndrome, posterior dislocation of the lens, homocystinuria, inferonasal displacement, and Marfan syndrome, superotemporal dislocation. So which of the following is not a correct match? Try to answer. So what happens in a ectopia lentis, or what is the subluxation of the lens? That the position of the lens is not in your anatomical position. Normally the lens is present in a fossa which is called patellar fossa. Now when the lens, a part of lens is not there in the patellar fossa, this is called a subluxation of lens or ectopia lentis. Now congenital ectopia lentis, it is most commonly seen in the superotemporal side. Homocystinuria, it is basically seen in the inferonasal side. Marfan syndrome, it is basically seen in the superotemporal side. But remember, the Weil-Marchesani syndrome, it is not seen in the posterior part. Here the lens is basically subluxated anteriorly. Okay, so the signs or the features of a Weil-Marchesani syndrome is opposite to what we see in the Marfan syndrome. In the Marfan syndrome, we get long limbs, we get long height. In a Weil-Marchesani syndrome, we see the opposite. We see a short stubby character. In a Marfan syndrome, you would get a superotemporal subluxation. In the Weil-Marchesani syndrome, you would see the anterior subluxation. Okay, so the answer here is B. Chalo, let's move to another question regarding the ectopia lentis. So question is, first you see this picture. So from this picture you try to attempt the question. Usually associated with the Marfan syndrome, crescent reflex is seen on retinoscopy. Patient may need systemic evaluation also. Extracapsular cataract extraction is the treatment of choice. Try to answer. So we all know this is a patient who is suffering from ectopia lentis. Okay, I told you that this is the superior temporal subluxation, and the superior temporal subluxation is seen with the Marfan syndrome. So this is the correct option. If you can see these two reflexes, this is the phakic reflex and this is the black shadow which is coming from the aphakic area. So this is the aphakic reflex, and the aphakic reflex basically is a crescent shape. So we see a crescent reflex. Okay, because this patient is having a Marfan syndrome, the patient may be having some systemic features as well, like a patent ductus arteriosus, mitral valve prolapse. So he may need also a systemic evaluation. Extracapsular cataract extraction, this is not the treatment of the choice. So there are two treatments that you can do in these patients. Can anyone tell me what are the treatments that we can do in a patient of the ectopia lentis? So the two treatments that you remember here is, before I go that, I just tell you this is the phakic reflex and this is the crescent reflex that we are talking about. So the treatment of the ectopia lentis you can do in two varieties. Now first is you can remove the whole of the lens with its capsule. When I remove the whole of the lens with its capsule, I call it ICCE. Have you ever heard the name? Intracapsular cataract extraction. Okay, this is the ICCE. The next type of treatment is, what we do is, we just, before doing a phacoemulsification, we put a stabilization ring inside the capsule. Okay, we put a stabilization ring inside the capsule which would hold the capsule and avoid any movement of the capsule. What is this called? The name is Sioni ring or a capsular tension ring. Okay, so these are the two ones. As Dr. Raj already have told us, they are the Sioni's ring and the capsular tension ring. And once the capsule is stabilized, the lens is stabilized, then you can go with the phacoemulsification. Okay, so this is the treatment that we can do in the patient of the extracapsular cataract extraction. Okay, the next question is, we have to match the wrong of the one. So your options are Marfan syndrome, superior temporal dislocation, shield cataract, atopic dermatitis, myotonic dystrophy, anterior subcapsular cataract, galactosemia, oil droplet cataract. Okay, let's see all the options one by one. We discussed it many times. In the Marfan syndrome, you can get a superior temporal subluxation. You can remember it with the mnemonic MUST. Then shield cataract is basically seen in the atopic dermatitis. It is basically a anterior subcapsular cataract. This is the lens and you get a cataract like this. This is called a shield cataract, like a shield. Okay, so you can remember it with the mnemonic SAD. Then you have myotonic dystrophy. Myotonic dystrophy, you basically do not see the anterior subcapsular cataract. As Lakshmi have given me the figure, this is basically a Christmas tree cataract. You can remember it with the mnemonic Merry Christmas. Okay, and in the galactosemia, you see a oil droplet cataract. So the oil droplet cataract is like this. You can remember it with the mnemonic GOT. So these are the various types of cataracts which are seen in the systemic disorders. Also remember that there is one more thing that you can remember, that sometimes you can have a cataract like this. This is called a rosette cataract. Can anyone tell me where you see a rosette cataract? So T goes with, there are two T's, they go with trauma. So the rosette cataract is basically seen in the patients who are having a blunt trauma. Chalo. Then we come to our next question. Next question is, a patient presented to the advanced cataract with a corneal opacity. To know the prognosis, potential gain in the vision of the patient, we can do which of the following tests? Your options are laser interferometry, photostress test, Amsler grid test, or swinging flashlight test. So what happens that whenever you are doing a cataract surgery, the patient would ask that, sir, after the cataract surgery, how much can be our vision? So what we usually do is we do a good refraction of the patient. We do take a pinhole vision. But let's say if there is a corneal opacity in the front of the pupil, or if there is a very advanced cataract, even with the pinhole, the patient would not be having a good vision. To get the maximum visual potential of the patient, what you can do is you can do a test where from any of the clear area. So let's see, this is the lens and this is my pupil and here is my corneal opacity. This is an advanced cataract. So when we take the vision from the center, the patient would not have a good vision. But what we do is we basically make a pattern over the retina and we provide a very sharp laser pattern. Okay, so laser is a very focused light. Okay, only a single wavelength light. We basically make a pattern with the help of laser directly over the retina. Are you getting my point, Lakshmi, Raj? So what it does is it basically causes the pattern directly stimulate the retina. So what the patient does is patient can basically see the pattern. If he can appreciate the pattern, and every pattern is regarding like certain lines. So they may be having more thickness or a smaller thickness. So every pattern basically corresponds to one visual acuity. Let's say this is 6/9. This is 6/18. So they are analogous to any specific scale. If the patient is able to make and he can see that I can see this pattern. So this means he has a visual potential of around 6/9. Okay. So that is basically helping you to tell how much can be the visual potential after the surgery. If you are getting this point, give me a thumbs up. This is called laser interferometry. Okay. This pattern and this test is called laser interferometry. It is basically very important in those patients who are having an advanced cataract or a corneal opacity. Okay, chalo, let's move to our next question. Next question is, a patient presented with a picture as shown below and a progressive diminution of vision. What can be the potential cause of endophthalmitis after the treatment of this condition? Try to answer. So first of all, we have to appreciate what is this picture showing as. If you can see, there is an intraocular lens and behind the intraocular lens and in front of the intraocular lens, there is a opacity. So there is a capsular opacification, okay, which is both anteriorly as well as posteriorly. No, Pooja, to prevent the age-related cataract, you cannot prevent. The other causes of pre-senile cataract, you can prevent by preventing the condition. Okay, not by any drop. Anyways, so this is something where you are having the opacification of the capsule. It is called a after cataract. Do you all agree? Now, how we treat this after cataract? We basically do a laser in the central part. Okay, we do a laser in the central part of the capsule, and through this the light rays can then basically go and directly reach the retina. Okay, but the problem is sometimes there are few bacteria which are there on the capsule. These bacteria are quiet bacteria and they do not usually do any infection in the vitreous cavity. But as soon as we do a YAG laser capsulotomy, as Raj have told us, they bacteria they get access to the vitreous cavity. Are you getting my point? They get access to the vitreous cavity, and then they can cause a fulminant type of endophthalmitis, and the bacteria most commonly that is responsible is the Propionibacterium acnes. Okay, so the late onset endophthalmitis after yak capsulotomy, this is basically seen with the help with the Propionibacterium acnes. Is it clear, Raj? Okay. Chal. With this, we come to our next question. Next question is, usual placement of IOL in a phacoemulsification surgery is above the iris, between the iris and the anterior capsule, between the anterior and the posterior capsule, or below the posterior capsule. Try to answer. So after a cataract surgery, what we do is we put a intraocular lens for the visual rehabilitation of the patient. And remember, this intraocular lens is usually placed between the anterior and the posterior capsule. Okay, between the anterior and the posterior capsule. This is the physiological position of the intraocular lens, and it is called in the bag implantation of the PCIOL. Okay, in the bag implantation of the posterior chamber intraocular lens. Okay, then we have the next question, please. Which of the IOL formula is used in the calculation of IOL power in cases of post-LASIK eye? This was a previous year AIIMS question. So the answer here is Higgins formula. The usual formula that we have studied in most of our textbooks is the SRK formula. But now we have got many modifications of the SRK formula which can tell us about the intraocular lens power more correctly. The most important of them is basically the SRKT formula. But special formulas can be used in the special situations. If the patient has got a post-LASIK eye, now what is happening there is that first of all, let's say this is the normal corneal curvature and the patient is having a myopia. So what we do in the LASIK surgery, we flatten the curvature. Okay, we flatten the curvature. So first thing, we have basically changed the curvature of cornea in a LASIK. The second thing what we does is we basically change the corneal thickness as well. So the formula which is basically made is called Higgins formula, and Higgins formula has been seen as a very important formula which can be used for the calculation of IOL power in the post-LASIK patient. You do not have to go into the details of them. I am just giving you the names of the various formulas which can be used in the various cases. What you can do is you can just basically take a snapshot of this slide and basically note it down in your ophthalmology notes. Okay, so just I tell you one by one. If the patient is having a long axial length, let's say patient is a high myopic, you can use Holade 1 or SRK2T formula. If the patient is having a normal axial length, okay, then normal axial length is defined as more than 22 millimeter and less than 24.5 millimeter. There you can use the SRK2, SRKT and the Hofer formula. Okay, you can use the SRK formula, but these are the more accurate ones. SRK2, SRKT and the Higgins formula. Then we have the post-LASIK patients. In the post-LASIK patients, what we can use is the Higgins formula, and we can also use the ASCRS calculator. What is the meaning of ASCRS? It is the American Society for Cataract and Refractive Surgeries. They have provided a cataract calculator online where you can put the values and get the IOL power. If the patient has undergone a vitreoretinal surgery, okay, and there is a silicone oil filled eye, in that case, if you have to put a intraocular lens, you would calculate the intraocular lens power with the SRK formula, and there you have to add a 3 diopter or a 3.5 diopter. Okay, you calculate it and basically add 3 to 3.5 diopter for the IOL power calculation. Now, if you have to put a intraocular lens after a keratoplasty, that means after a corneal transplant, what you would do is you would take the keratometry of the other eye. Okay, let's say you have to put it in a scarred cornea. In the scarred cornea, you would not able to get a keratometry there. So what you do is you take the keratometry of the other eye and basically then you can put it as the intraocular lens power there. Okay. Then if you have a congenital cataract, in a congenital cataract, if you have to give the power, the intraocular lens, if the patient is less than 2 years of age, then you would give a 20% under correction. If the patient is less than 8 years of age, then you would put a 10% under correction. Now what this actually means, let's say the SRK formula is calculating the IOL power as the 20 diopter. So up to 2 years, what you would do is you would do a 20% under correction. So you would give a 16 diopter there. If the patient is, let's say, 6 years of age, then you would give a 10% under correction. So you would give a 18 diopter. Now why you do this? Because remember, this child, the axial length would grow with age. Okay. So the axial length, which is 17 millimeter at birth, would basically grow with age. The corneal curvature would change with age. So you have to make a correction for this also. That's why you are doing a under correction in these patients. Okay. Chalo. Let's move to our next question. Next question is not true regarding the pediatric cataract. Your options are: injections of drug in gestational period can lead to it. It is usually reversible. Unilateral cataract needs urgent cataract surgery, may lead to amblyopia. So definitely the answer here is B. Now remember, any type of cataract is not reversible. There is one exception to that where the cataract is reversible. Can anyone tell me in which case the cataract can be reversible? So have you seen the oil droplet cataract? Oil droplet cataract is a cataract which is seen in galactosemia. Now it is the only type of cataract which can be reversible. Not always, but which can be reversible in those patients where you stop the galactose and then they can have the resolution of that. But this happens only in the initial cases. Otherwise, the cataract is not a reversible. Let's see the other options. Ingestion of the drugs in the gestational period can lead to it. Definitely yes. Can Raj, you tell me any drug which is responsible for the pediatric cataract or congenital cataract? Have you ever heard the name thalidomide? So thalidomide have been seen which is responsible for the congenital cataract. Also, the corticosteroids also have been seen. If the mother, you have to give a corticosteroid for any condition, that can also lead to increased incidence of the congenital cataract. Now, what is happening in a unilateral cataract? So, in a unilateral cataract, what is happening is there is a stimulation deprivation amblyopia. Okay. So, because to prevent this stimulation deprivation amblyopia, a unilateral cataract basically needs a urgent cataract surgery. Okay. So, option C and option D both are true here. Is it clear, Raj, Lakshmi, everyone? Okay, chalo, let's move to our next question. Next question is: a patient presented with a hypermature senile cataract, deep anterior chamber, cells and flare, and very high intraocular pressure. What is the best management for the patient? So before you go to the question, you go to the answer, please see the various hints that are given here. The patient was having a hypermature senile cataract, a deep anterior chamber, cells and flare. What is the flare? Flare are proteinaceous particles in the anterior chamber and the patient is having a very high IOP. So can you tell me what is the diagnosis here? So very good, this is a phacolytic glaucoma. Do you agree to me? This is a phacolytic glaucoma. Why I am saying that it is not a phacomorphic glaucoma? The reason is that the patient is having a deep anterior chamber. Okay. So whenever we are having a phacolytic glaucoma, what is the first thing that we do? The first thing is we control the intraocular pressure. We give the anti-glaucoma medications, and with the help of anti-glaucoma medications plus steroids. Why I give a steroids? I give the steroids to decrease the inflammation. As soon as the inflammation is gone, then we remove the final part which is responsible for this inflammation and this high IOP. This is the hypermature senile cataract. So we do a cataract surgery in these cases. Okay. So medical management of the intraocular pressure followed by the cataract surgery is the first and the most important treatment strategy in any type of lens induced glaucoma. This is true for any type of lens induced glaucoma. Okay, whether it is a phacomorphic glaucoma, whether it is a phacolytic glaucoma, whether it is a lens particle glaucoma, in all of the cases, this is the treatment strategy. Okay, so next question is, during cataract surgery in a patient who is on blood thinners and taking antihypertensives, there was a sudden increase in the IOP. The anterior chamber became shallow and there was exodus of the intraocular contents from the surgical incision site. What can be the potential cause? Try to answer. So Lakshmi, in the bilateral cataract also we would do the surgery as soon as possible. The problem why this question was given was of the unilateral cataract, that whenever the patient is having a unilateral cataract, the child can do all the things very normally. So what is happening is the parents are not very much convinced for going for a cataract surgery in a small child, because what is the conventional society thinking, that the cataract is something which happens in old age. So they basically take second opinion, third opinion, homeopathic, Ayurvedic, everything, and by the time they come back, the vision is lost. So that's why in the cases of bilateral cataract, because the child is not basically very much active because of the stimulus deprivation, so they are more convinced. In a unilateral cataract, the child can do everything, so they say that my child is absolutely fine. Why we should go for a cataract surgery? Let's wait for some time. Do you get my point? So if this is asked in your exam, usually the bilateral cataract they won't ask because it is very obvious, but if they ask, then also you would do as soon as possible. Okay, so here let's see what are the hints that are given in this question. So the first thing that here is that the patient is on the blood thinners and was taking antihypertensives. So can you all appreciate that this patient was having a more tendency for the bleeding? Do you all agree? So ये patient में chances काफी high थे कि patients में intraoperative bleed हो सकता है. So what was there is during the cataract surgery there is a sudden increase in the IOP. What the increase in the IOP has done is it has basically caused the anterior chamber shallowing and there was an exodus of the intraocular contents from the surgical incision site. Now I should make a diagram for this. What is happening is this is your sclera. Beneath the sclera we have the choroid and here we have the blood vessels. So these blood vessels are, we all know that choroid is the most vascular layer. These vessels are beneath the sclera and above the choroid. Now first thing is there was a very much high tendency of the bleeding because the patient was on blood thinners and antihypertensive. And the second thing is that what happened was there was during a cataract surgery there was a sudden decompression, so this caused a bleeding inside the suprachoroidal space. Now what is the suprachoroidal space? The suprachoroidal space means the space between the sclera and the choroid. Do you all agree? Now what this has done is it has basically caused a massive space, a massive bleeding inside. There is a massive bleeding inside, and because of this massive bleeding, what is happening is all the intraocular content, it is going outside. Okay, so every intraocular content is pushed in forward. Do you all agree? Lakshmi, Hippal, Raj. So सारा intraocular content, because यहाँ पे bleeding हो गई, सब बाहर की तरफ जाने लगा. This is basically causing the high IOP, this bleeding, plus this all content which is going forward is causing a shallow anterior chamber. So what is this procedure called, or what is this phenomena called? This phenomena is called a suprachoroidal hemorrhage. Is it clear, Lakshmi? So this is the suprachoroidal hemorrhage. So what is the cascade of events? There is a sudden decompression of the area, and this sudden decompression of the area has caused a massive hemorrhage in the suprachoroidal space. This massive hemorrhage in the suprachoroidal space is basically causing the vitreous and all the intraocular content to go inside, which is causing a high intraocular pressure, and that finally causes a catastrophic event for the patient, where the patient loses the eyeball. This is the last thing a surgeon would do, last thing a surgeon would want during a cataract surgery. Okay, chalo, let's move to our next question. A patient presented with the anterior segment photograph like this and blurring of vision. All of the following are true regarding this patient except. So you can see the opacity here, the onion ring or hole like opacity here. The rest of the lens is normal. I would just show you a transverse section of this patient also. So this is your lens and your opacity is here near the posterior capsule. So my question is, all of the following are true regarding the patient except. Your options are more discomfort in the bright light, usually associated with the Mittendorf dot. The surgery may cause posterior capsule rupture, deposition of calcium in the posterior capsule. So very good, Raj. This is not a calcium deposition. This is basically the opacity of the fibers that is happening. So Shikhar, absolutely correct. This is not the deposition of the calcium. This is basically the high molecular weight 3 and high molecular weight 4 collagen which is coming, and basically what is happening is during the cataract surgery, the non water soluble proteins, they increase in the concentration like albuminoids as compared to the water soluble proteins. Okay, so the answer here is D. So what this patient is having is, this patient is having a posterior polar cataract. If you can appreciate in this picture, this is a very, very good picture which I have got from one of my patient. This is a posterior polar cataract. Okay, so what is happening in a posterior polar cataract? There is a more discomfort in the bright light. Now you would ask me, sir, why? Why there is a more discomfort in the bright light? So tell me, whenever there is a bright light, would there be a miosis or mydriasis? Would there be a constricted pupil or a dilated pupil? So remember, whenever this happens, there would be a constricted pupil in the bright light. So if you have a bright light, the light rays can basically go from the center of the pupil. Okay, so they would basically hit the posterior polar opacity, and that it would cause the blurring of vision. So the blurring of vision is more in the miosis than in a dark light. Okay, the second is, sometimes this is associated with a opacity which is there from birth. This is called a Mittendorf dot. This is called a Mittendorf dot. Now, what we do in these patients, we basically do a cataract surgery and we try to remove this opacity. But during the cataract surgery, what can happen is that if we try to remove this opacity, this can cause the rupture of the posterior capsule. So rupture of the posterior capsule can happen and the intraocular content can go into the vitreous cavity. Okay, so this is called the phenomena of lens drop. So we get a posterior capsule rupture, and in the posterior capsule rupture we get a phenomena of lens drop. Okay, so these posterior polar cataracts, they are very much notorious for the getting a posterior capsular rent. Okay, so all options A. Let's see the options once again. So more discomfort in bright light as compared to dark light, this is correct. Usually associated with Mittendorf dot, this is also correct. The surgery may cause a posterior capsule rupture, that is also correct. Another association is a PHPV. Have you ever heard the name? Anyone? What is PHPV? So it is persistent hyperplastic primary vitreous. In that cases also, you may be having a persistent hyaloid artery, which is basically attached to the optic nerve head. This can also cause a posterior polar cataract. Okay, chalo, let's move to our next question. A patient during a cataract surgery had a posterior capsule rupture. Now, all of the following can be the potential complications of this, except your options are macular edema, retinal detachment, glaucoma, or posterior capsule opacification. So the answer here is D, that is posterior capsule opacification. So it is very obvious. When the posterior capsule is already ruptured, there is no place the equatorial cells can get deposited. What is the posterior capsule opacification? That the equatorial cells, which are there at the equator of the capsule, they basically migrate and get attached to the posterior capsule and cause a posterior capsular opacification. When there is no posterior capsule, because of the posterior capsule opacification, there is no question of a posterior capsular opacification. Now, why these options can be possible? So first of all, our option is macular edema. Now, why there can be a macular edema in these patients? Now, during the cataract surgery, if there is a posterior capsule rupture, the chances are that the various components of the cataract surgery or the various things that we use in a cataract surgery like viscoelastic, etc., can basically go in the vitreous cavity and they can cause an inflammation there. The second thing is that any inflammatory material, remember, any surgery basically causes an inflammation. Any inflammatory mediator can go inside and cause a cystoid macular edema there. Okay. So the most common cause of the decrease of vision during a posterior capsule surgery is a posterior capsule rupture, is the macular edema. Do you all get my point? Now, second thing what is happening in some times is that the converse can also be true. Now, this is your eyeball and behind the lens we have a fluid here, a jelly-like fluid. What is the name of that fluid? Which is basically there posterior to the lens, attached to the retina. Now this is the vitreous. Now when there is a posterior capsule rupture, this vitreous can also go in the anterior chamber. Okay. Now when this vitreous, which is very closely attached to the retina, it goes in the anterior chamber, it can basically cause a traction to the retina. Are you getting my point, Raj? So vitreous basically attach होता है retina से, वो traction apply करेगा and this traction may cause a retinal hole. Okay, a peripheral retinal hole it can cause, and this peripheral retinal hole can then further cause a retinal detachment. Okay, so you can have a retinal detachment. Now this vitreous can also go and block the trabecular meshwork. And when this vitreous can basically go and block the trabecular meshwork, this can also cause a rise in the intraocular pressure, which can cause a glaucoma. Do you all agree with me? So this is the pathogenesis of the various complications which can happen during a posterior capsule rupture. Okay. So before I go to my next questions, I would be just telling you that there is a offer in the Unacademy Plus subscription as well as in the Iconic subscription. If you want to go for a 3-month subscription, you would get a 1 month free of cost. I know that all of you are on the Unacademy Learning app. If any one of you is not available, you can just go and basically use my code OPHTHAL10 to unlock the free platform as well. Also, I am telling you that if you want to go for a 12-month subscription, you would get a 2-month subscription off, and there is a free NICT grand test on 13th of June at 8 p.m. and there is a free grand test for the NEET PG on June 13, June 20 and June 27. Okay, so you can use my code OPHTHAL10 to unlock the free platform. Okay, use the code OPHTHAL10 to unlock the free platform. Okay, so let's move to our next question. Before we come to the next question, Dr. Raj have basically given us a doubt. So question is, malignant glaucoma is also possible here? No, Pooja, it is not the tractional retinal detachment. Whenever there is a hole, this is causing a rhegmatogenous retinal detachment. So theoretically, malignant glaucoma is possible, Raj, but it is more commonly, malignant glaucoma can be there after any surgery, any intraocular surgery can cause a malignant glaucoma. But malignant glaucoma is more common in those situations where you have the injury or where you have a spasm of the ciliary processes. Okay, so it is more commonly seen in the trabeculectomy as compared to the cataract surgery. Theoretically, yes, but practically, after seeing almost more than 5 lakh cataract surgeries till now in my young age, I have never seen a malignant glaucoma happening after a cataract surgery. But theoretically, yes, it can happen. Okay, chalo, let's move to the next question. More commonly, it is seen, Raj, in those cases where there is itself a primary angle closure glaucoma. In the primary angle closure glaucoma with cataract, if both are there, you have removed the cataract, but the angle closure component is already there. You have not basically treated the angle closure component. Then there can be a spasm of the ciliary processes and they can go posterior to the intraocular lens and cause a malignant glaucoma there. Is it clear, Pooja? Raj? Okay. Chalo, let's move to our next question. Next question is, anterior lenticular opacities are seen in which of the following drugs? Your options are chloroquine, amiodarone, phenytoin or lithium. So phacomorphic, I would not see the malignant glaucoma there. It would be a secondary angle closure glaucoma. So very good, Dikshita. The answer here is not A. I would be saying that it is B. So chloroquine can cause and lenticular opacities, but they are not usually the anterior lenticular opacities. The anterior lenticular opacities are more commonly seen with the amiodarone. The drugs which can cause the lenticular opacities, you can just remember it with the mnemonic ABCD. So A goes with the amiodarone, B goes with the busulfan, C goes with the chlorpromazine, and D goes with the dexamethasone or any type of steroids. Okay, chal, let's move to our next question. So next question is, a patient came to the OPD with senile cataract. He was posted for a cataract surgery. His axial length is 25 mm and keratometry is 45 diopter. The IOL to be put is having a constant of 118.4 mm. What would be the best IOL power that we can put in the patient? Try to answer. you have to put a SRK formula here. I am just giving you a hint. You have to put a SRK formula here. You can just write it on a piece of paper and then try to answer. SRK formula is A minus 2.5 into axial length minus 0.9 into K. K is keratometry. So what is A here? A constant. Now A constant is very specific for a particular lens. So it is 118.4 minus 2.5. What is the axial length here? Axial length is 25 millimeter. So is the patient myopic or hypermetropic? So patient is basically a myopic patient. Okay, minus 0.9 into 45. So that is how the final call would be. So the patient would be having a 118.4 minus 62.5, okay, minus 40.5. So we have, what would be our final answer? It would be around 15.4 or 15.5 diopter. Is it clear, Raj? So remember, just seeing the question, you do not get worried. Okay, sometimes what we see is that we basically know all the one-liners or sometimes clinical situations, but whenever we get numericals, we get a phobia for that because we have not studied maths for last 8 to 10 years. So don't worry about that. Always, if you are basically having any type of question, you think about the physics, you think that you have studied much more complicated scenarios, just use your mind. So this was a very simple question. Do you all agree? We all have read about the SRK formula, which is A minus 2.5 into axial length minus 0.9 into keratometry. If you just put all the values here, very easily you could have got the answer. Okay, chalo, let's move to our next question. So next question is, most important side effect of the type of intraocular lens implanted here as shown in the picture is, your options are posterior capsule opacification, glare and halos in the night, decreased near vision, increased chances of endophthalmitis. What can be your potential answer? So what is this type of lens? What is this lens called? This lens is a multifocal lens. If you can see, there are lots of rings here. So what these rings do is, they basically make the light to focus on the multiple focal points. So the patient can see at the distance as well as patient can see at the near. So this is the advantage of this multifocal lens. But what is the disadvantage? That because of these rings here, there are the diffractions due to these rings as well. Okay, so they cause the bending of the light rays from the edges, and these bending of the light rays from the edges, they can cause glare and halos. Now these glares and halos, they are more commonly in the night. Why in the night? Because in the night there is dark, and dark there is the dilation of the pupil. Okay, and when the pupil becomes dilated, more and more rings come in front of the light. Are you getting my point, Raj, Pooja? So more and more rings come in the front of the light, so there are more glare and halos in these type of patients. Okay, so tell me here, what is the component? We have a hard intraocular lenses and we have a foldable intraocular lenses. So the hard intraocular lenses, they are made up of, anyone who can tell what is the material? It is PMMA. Have you ever heard the name? Polymethyl methacrylate. Polymethyl methacrylate, they basically make a hard lenses which is basically put whenever we do extracapsular cataract extraction, and also in the cases of the ICCE, where we do a intracapsular cataract extraction and put a anterior chamber intraocular lens. Okay, so the foldable lenses are the ones which can go after a cataract surgery, a phacoemulsification surgery, and get positioned in the bag. So this is the lens which we use. It is not hydroxymethyl hema, it is basically the acrylic lenses. Okay, Raj, they are the acrylic lenses which are the foldable lenses. Okay, chalo, let's move to our next question. Next question is phakic IOL. So sometimes we put a intraocular lens inside the eye without removing the natural lens. This is called a phakic IOL. So this phakic IOL is basically used in which of the following conditions? Correction of presbyopia, correction of small refractive errors, correction of very high refractive errors where LASIK is not possible, correction of astigmatism. So very good, Shikhar. You deserve a chocolate from my side. There is a very important type of lenses which are called phakic IOLs. The two types of lenses are the intracolumnar lens. They are called ICL, and the other one is the IPCL. So do not go into the details of what are the ICL and what are the IPCL. They are basically the phakic IOLs. Okay. So I write it here, intracolumnar lenses. So ICL, this is the trade name of a company, the Star Vision, which is producing it from the Switzerland. The IPCL is the Indian variety, which is basically produced by Care Group. So these are the very important phakic IOLs. Sometimes what is happening is there is a thin cornea, and because of the thin cornea, you cannot do a LASIK in the patient. But to reduce the refractive errors, what you can do is that you can put this intraocular lens in the space between the iris and the crystalline lens. This is the crystalline lens. So what you do is you put the lens in this space. Are you getting my point, Singha? You get the lens in this place. This is basically called a phakic IOLs. Okay, so you have not removed the crystalline lens, but here you have put the lens beneath the iris and above the lens. This area is called sulcus. Poojan, it is not just minus 15. We have done phakic IOLs even in the cases of minus 28 or plus 20 also. So any refractive error can be corrected if the company can make a ICL, then we can put this ICL in any of the patient. Dr. Kamal Kapoor, who is my the director of the Sharpside Group of Eye Hospital, he is having the world record of putting it over in the minus 25 and plus 20 diopter patients also. So you cannot even imagine that a patient who is absolutely blind without a spectacles or with spectacles, he is having such a big lenses. In one day, he says that, sir, I can see everything without glasses. Can you even imagine about that? What is the quality of vision of that, or quality of life in that patient? So it is absolutely, in one word, I would say magical for the patient. The phenomena of phakic IOLs. Okay, chalo, let's move to the next question. Next question is, this is the metabolism of the lens that becomes most important in diabetes is anaerobic metabolism, hexose monophosphate shunt, aerobic or sorbitol metabolism. Try to answer. So I think all of you must be knowing it is the sorbitol metabolism. I would not go into the details. The sorbitol metabolism becomes more important in the diabetes, and this sorbitol, if that is accumulated, what is happening is that the patient would get a intumescent cataract. This would basically have a lot of water inside the lens, and then it would cause a intumescent cataract. Okay, chalo, let's move to our last question of the day. So this is, which of the following means IOL that can correct the astigmatism? So last question of the day, try to answer fast. Okay, we have few more questions after this also. It is not the last question. So very good, it is the toric IOL. So remember, whenever we have the astigmatism is corrected by the toric IOL. Now what is the meaning of toric IOL? Astigmatism, we basically means that there is a cylindrical power. So let's say this is the space at which we have to put a intraocular lens. And whenever we have to put an intraocular lens, remember there are two parts of an intraocular lens. Can you tell me what are these two parts? I have just made it here. So this one is called a haptic, and this one is called a central part through which the light rays goes. This is called a optic. So when we have to put it in the sulcus region, let's say there is a astigmatism. So there are two holes in the optic, and we basically put the IOL in such a way, it is designed in such a way that our haptics are basically aligned in this direction. Okay, so let's say this is 180 degree. So I have put a lens which is there at 45 degree. Okay, so this is, we have basically rotated the lens in such a way that it is basically focusing on that areas where you are having the astigmatism. This is called the phenomena of toric IOL. So remember that what is now happening in a cataract surgery, let's say you have a grandparent who is having a -5 diopter. Now after a -5 diopter correction, what is the patient is having a -5 diopter sphere with -2 diopter cylinder also. The patient is having a cataract surgery. What we usually say is that the cataract surgery would remove the cataract and the patient would have to basically then use the spectacles. Now with the best of the technology, what are the two technologies which we can use to correct the astigmatism? One is the toric IOLs that I told you here, and the other is even femtolaser. So femtolaser can also basically correct even up to -1.5 diopter cylinder. So you can see that after cataract surgery, not only the patient vision is better, the patient get basically no glasses after the surgery as well. So if you can basically tell your grandparents that, sir, I would do a surgery for you, it would not only correct your vision would be so better, it would basically help you to avoid the glasses as well. The patient would be saying, wow, that what has happened to me. एक 70 years की grandmother आपकी जो है वो आपकी 23 year की friend से better हो जाएगी देखने में. She can study without the glasses. She can have without the glasses all the vision. So that is so wow feeling in a cataract refractive surgery. Okay, chalo, let's move to okay. Before I go to the next question, I would be just telling that there are. Please remember, on 13 June, that is tomorrow, we have the free grand test which is on 8 p.m. and 2:30 p.m. So sorry, 8 a.m. This is the NICT grand test, and we have the NEET PG grand test also. And we do not know what is happening in the government, what they are saying. Even I do not know, and I feel so much pained by all of you that you are not having even clarity that what is happening. But the thing is, we cannot do anything. We cannot blame anything. We are the doctors. We have to take the brunt of the society. And what we are doing is we are just as a doctor, I am basically thinking that the people are so ungrateful to us nowadays. But what you have to do is you have to basically keep your strength on and always have we will have a new Telegram group. I do not know. I have the older one. Anyways, and we always have to fight hard in this scenario. Okay. So before that, we are having a lot of new batches also which are going on. So there is a NEET PG seasons batch which has started from 16th of June. Okay, it would be having a high yield topic revision, test and analysis, previous year question, 3 grand tests. So after this, telling you these batches, we would continue our discussion. There are 4 questions left now. 3 grand tests, live interactive sessions, and new NEET PG pattern questions. So Dr. Sita Sudaraman would be telling you about the ophthalmology there. Okay. Now we have a target next 2022 batch also, which is from June to the November. That is also having the best of the educators and the best of the contents for all of you. You can join that session also. You have the FBBS Professional Year 1 batch also for the first year students. You have the MBBS Professional Year 2 batch also for the second year students. For the final year students, you can basically join whatever course that you want. Okay. Chalo. Continue with what I basically feel the best, that are the MCQs. Okay. So my next question is, which of the following is a relative contraindication of putting a intraocular lens? So my question is, which of the following is a contraindication of putting a intraocular lens? So what is happening is that sometimes there is so much uveitis that if we put the intraocular lens, there would be a very, very heavy fibrosis. And this heavy fibrosis, what it can do is, it can basically cause the damage to the intraocular lens, and the fibrotic strands which are there, they can cause the tilting of the intraocular lens. There can be massive posterior capsule opacification, and this is so commonly seen in the patients who are having a juvenile rheumatoid arthritis. So JRA is a very, very dangerous disease where you can have a very intense reaction, and it is a contraindication of putting a intraocular lens. Nowadays, with the improvement of the technology, what we are doing is that we are giving the oral steroids before the cataract surgery. So when we give the oral steroids before the cataract surgery, we can basically take care of the inflammation part also, and when this inflammation part is basically taken care, we do not get so much of fibrosis. So we start the steroids pre-operatively, we give the steroids post-operatively also, the systemic steroids, and we hope the best. We pray to the God before a surgery, during a surgery, and after the surgery, that the child should get a good vision. So this is the juvenile rheumatoid arthritis, which is basically the contraindication of putting an intraocular lens. So this is the only contraindication, and I would not say that contraindication, I would say relative contraindication of putting an intraocular lens. What are the other contraindication? The only other contraindication which I can think about is a very small eye. Very small eye. What I call it? I call it a nanophthalmic eye. Okay, इतनी small eye है कि हमारे पास intraocular lens ही नहीं बना. Okay, or which I told you, a 4-week child. I told you, unilateral cataract surgery. It has to be done in a very small baby. So even with the advent of the best of the technology, we are not having a very small optic lenses. And the problem is, if I put a very small IOL, even let's say a customized IOL, and then when the patient's age increases, then this IOL would float in the cavity. Okay, so a very small child or a patient who is having a nanophthalmic eye, it is very, very difficult to put an intraocular lens. We must be having a customized IOLs, and still it is very difficult in a 4-week-old child. Are you getting my point, Diksha? Move to our next question. The next question is, a patient presented with a blue dot cataract. What should be the best treatment for the patient? So remember, blue dot cataract is the most common lenticular opacity that we see in a small child. Okay, it is the most common lenticular opacity in the small child. The best thing about the blue dot cataract is we get the opacities all over the lens. We get the opacities all over the lens, but they are not hampering the vision of the patient. Okay, because these are small, very small opacities. They are not hampering the vision of the patient. So only thing that what you can do is you can just tell the patient to wait and watch and avoid any surgery there. Okay, chalo, let's move to our next question. So what is the most common visually debilitating cataract in the children? I talked about the most common Cataract, what is the most common visually debilitating cataract? Your options are blue dot, zonular, anterior polar, or nuclear cataract. So definitely it cannot be blue dot. Sometimes what the opacities are there, opacities are basically forming in the certain areas of the lens. Okay, so let's say these are the sutures, these are the anterior ones and these are the posterior ones. So the opacities are around the sutures of the patient. This is called a sutural cataract, or because they are in the specific regions, I call it a zonular cataract. Now zonular cataract is the most common visually debilitating type of cataract in the. So the answer here is B. Now if you can see in this picture, this is a USG-B scan. This is a USG-B scan. B means brightness. And if you can appreciate here, just give me a thumbs up. You are seeing some dusting of the vitreous humor. In the vitreous humor, this is my vitreous humor. You can see some mild to moderate amplitude spikes here. Okay. So this is the basically exudates which you can see on the spikes. Now these exudates which are there after cataract surgery, basically the patient is also having pain and redness. So they all are basically pointing towards the diagnosis of endophthalmitis. Okay, so this is all the diagnosis of endophthalmitis, and the first thing that we do in the endophthalmitis is we give the intravitreal antibiotics. So 4 millimeter from the limbus. Remember my words here. 4 millimeter from the limbus. What I do is, with the help of a needle, I put the antibiotic straight into the vitreous cavity. There is no role of the oral antibiotics, no role of the systemic antibiotics. The one that is the Ramband is the intravitreal antibiotics in these patients. Okay, so we use intravitreal antibiotics, and what this causes, this can cause the resolution of the infection inside. Why this infection is very, very important, why it is an ocular emergency? Because this infection can cause a permanent damage to the retinal cells. Okay, so that's why it is an ocular emergency. Never ever, okay, like Dr. Arnab Goswami, never ever use steroids in these patients. Okay, so steroids are not to be given in any patient of the endophthalmitis. Chalo, let's move to our next question. Next question is not true regarding this condition. This is pseudophakia with posterior capsule opacification, more commonly in acrylic lenses than the PMMA. ND-YAG laser is used for the treatment, also called Elching pulse. This is my last question of the day. So you all know that I told you again also, this is a posterior capsule opacification. And you can see there is an anterior capsule opacification as well as there is a posterior capsule opacification. Okay, so option A is absolutely correct. More common in the acrylic lenses than PMMA. So remember, the PMMA have the more incidence of the PCO and it is not the acrylic lenses. Okay, so the answer here is B. The laser that we use here is called a ND-YAG laser. Do not confuse it with the double frequency ND-YAG laser. Diksha, Pooja, Lakshmi, Raj, can you tell me where I use a double frequency ND-YAG laser? I do it in the patients who are suffering from proliferative diabetic retinopathy. Can you tell me the procedure, the name of the procedure? It is pan-retinal photocoagulation. Okay. So double frequency ND-YAG, you use it in the pan-retinal photocoagulation. The single frequency ND-YAG, you use it in the patients of YAG capsulotomy. Okay. And they are definitely called Elching pulse. Now here there is another question which is having a similar name, that is called Elching spots. Have anyone heard about this? Elching spots. Where we see Elching spots? Elching spots is basically seen in the patients who are having a hypertensive retinopathy. Have you ever heard the name? So there are infarcts which are basically happening in the choroidal region, in the choroidal capillaries. the infarcts happening in the choroidal capillaries, they are called Elching spots. Do not confuse it with the Elching pearls which you see in the posterior capsule opacification. Is it clear, everyone? So we have, in this 1 hour session, we have discussed all the important MCQs that can be asked from these topics. So hope you would have liked the session. Those students who have joined later, they can see the video recording also. And if you want, you can join the Plus subscription, which have the live classes, live test and quizzes, batch course, structure schedule. And in the Iconic subscription, with that, you would be also having the video lectures, question bank, rapid revision course. And use the code OPHTHAL10. So use the code OPHTHAL10 to unlock the free platform and give wings to your preparation. Thank you very much for attending this session. Before you leave the session, I would just request you to subscribe for the channel and do not forget to like the video. Okay, please like the video, subscribe the channel and hit the bell icon for the notifications. Thank you very much for attending the session. Good night, Jai Hind, and thank you.